All right, we can go ahead and get started. So welcome everyone to the FPMRS Fellows webinar series. This is a joint effort between AUGS, SUFU, and SGS, and we are grateful for their support of this endeavor. I'm Caroline Cox, the third-year fellow at the University of Michigan, and I'll be moderating today's webinar. So today's webinar is on the anatomy of level 3, surgery, prolapse, and operative failure. It will be presented by Dr. John DeLancey, and our panelists today include Dr. Visco from Duke and Dr. Handa from Johns Hopkins. The webinar will feature a presentation for 30 to 40 minutes, at which time we'll allow for discussion between our panelists. We will then open our webinar to questions from the audience for the final 15 minutes. In case anyone is here watching for the first time, I'd like to briefly review some housekeeping items. So, this webinar is being recorded and live streamed, and all participants will remain on mute, but please use the Q&A feature of the Zoom webinar to ask any of our speakers questions today. We will try to address as many of those questions as we can within the hour. And then you can use the chat feature in Zoom if you have any tech issues, and the AUG staff will be monitoring that chat and can assist you as needed. At the end of the webinar, you'll be prompted to complete a brief survey and provide feedback about the session. I also wanted to let everyone know that our next webinar is scheduled for this Friday, April 24th at 10:30 Eastern in the morning, and that's titled Surgical Management of Constricted or Obliterated Vagina. That will be presented by Dr. John Gebhardt with panelists Dr. Gutman and Dr. Ferrando. Please visit the AUGS website to sign up. So shortly we'll hear from Dr. DeLancey, who is the Norman F. Miller Professor of Gynecology at the University of Michigan. He has focused his career on understanding the basic anatomy and biomechanics of the pelvic floor and developing scientific tests to allow research to answer questions about the structures that fail in causing prolapse. He has also worked hard to understand the mechanisms of urinary incontinence and birth-induced pelvic floor injury, and has an active surgical practice focused on treating patients with complex and recurrent pelvic floor defects. So, Dr. DeLancey, you can go ahead and share your screen.
Great, thanks, Caroline. Let me just get my slides up here. Great. And I wanted to thank Peter and AUGS and SGS for this opportunity to be able to talk with you about some things that have to do with level 3 anatomy. I don't know about you, but for me, I had a really good idea about what the pelvis looked like from above. Laparoscopically, you can see the tubes and the ovaries and everything. And I think we all have a pretty good idea about what things look like in the vulva and the vagina that you can see through a speculum. But there's a lot of stuff in the middle that's kind of been a mystery. And I think that over the course of time, many of us have realized the importance of some of the structures down at the lower part of the vagina that closes the vagina. And I'm really happy that Tony Visco and Vicky Handa are going to be here to discuss, because they've both done some very important original work that I'll be mentioning just briefly. I've often thought about our research group kind of like these pilots in World War II who are trying to understand how a parachute works, that you can kind of pull on a cord and see what happens in the operating room. You can do things and see what the results are. But the problem really in terms of understanding the science of the pelvic floor that we need to be able to guide our treatments is the fact that this is all we really get to see. It's a really limited view that people have had for the last 100 years or so that limits our ability to scientifically determine which of the many ideas that we've had are true and which of the many ideas that we've had really can't be supported by evidence. Wonderfully, in the last 20 or 30 years, the advent of magnetic resonance imaging has changed all of this, and that we can see a complete view of the pelvis. And not only can we see it, but we can make measurements by putting an XY coordinate system, looking where a specific structure is. Here, let's just say the external os of the cervix, and then seeing how things move under increases in intra-abdominal pressure. And this is going to be the basis of a lot of what I talk about today is our improved understanding about what goes on. And I've been a surgeon for quite a while, and I've tried a lot of different operative approaches. And I think I can say that I have good solutions for my patients, but I think all of us face the fact that even our gold standard operations have a substantial failure rate. Here is the Pelvic Floor Disorders Network, wonderful 7-year outcome study from abdominal sacral colpopexy. And you can see that even in the best of hands, when you think carefully about it, at the end of 7 or 8 years, there's about a 25% failure rate. And so the question is, how are we going to try and improve upon that? Now, when you think conceptually, randomized trials have been tremendously important in comparing the different treatments that there are. And I think in this standard table that people are used to seeing, there's good success and bad success, and there are good complication profiles and bad complication profiles. And it's easy with clinical trials to be able to weed out the complication operations, to weed out the low success operations, and then give rise to these operations that are the best ones that we have. But the problem is, if our best operation has a 25% failure rate, how do we get up here into the higher success and fewer complications range? And I would suggest that just doing slight modifications is probably not going to get us there. We're probably going to need some new ideas that I would suggest comes largely from research into what each individual woman's unique structural failure is that results in her prolapse. Not whether she has a cystocele or a rectocele, but what are the structural failures, for example, that led her to have her particular cystocele. Engineers are very familiar with failure analysis. This is the Tacoma Narrows Bridge that had a catastrophic failure. You can see it here where the roadbed is disrupted. And if you were to say what went wrong, you could find a lot of different things that don't look right. But the question is, were these the cause of the failure or the effect? I think many of you know that it was this harmonic oscillation of the roadbed that was the thing that caused it to fail. Engineers analyzed that. They've now built an understructure to bridges so that they're stiffer. It's never happened again because they understood why the specific failure happened. So we need to understand a little bit about prolapse in order for us to be able to start to do this kind of structure-specific failure analysis. And prolapse is really a pretty simple phenomenon. There's an intern finger on a surgical glove here, and if you compress the air, it drives it outwards. Diagrammatically, you can see this is an enclosed area with an increased pressure that causes this invagination to come outwards. And that, if you will, is vaginal prolapse or uterovaginal prolapse in its simplest form. And there are really two major factors that prevent that from happening. The vagina is attached both with the cardinal and uterosacral ligaments and the perivaginal attachments that connect the vagina to the walls of the pelvis. The muscles and the connective tissues of the pelvic floor close the bottom opening so that there's no place for things to fall out. And it is a combination of these things in a specific and unique arrangement to the pelvic floor that's really the thing that allows us to understand the interaction between connective tissues and pelvic floor closure. And I'm going to talk because I think a lot of what we're learning now is about these interconnections. A few years ago, we decided to try and actually test specific structural failure hypotheses to see which areas were the most likely to have operative failure. We used a technique called stress 3D MRI. It allows you to make a three-dimensional model of the entire pelvis. And then you can actually make measurements of specific things like how long the apical fibers are, how big the gap in the perivaginal attachments between the arcus tendineus and the side of the vagina are. You can see the length of the vagina, you can see the width of the vagina, and you can see it not only in normal individuals, which you see over here on the left, but you can also see it in individuals with prolapse so that you can gather data to actually be able to determine which sites fail, who they fail in, and how often that failure is associated with prolapse. So this is what we found. There is a substantial contribution to prolapse from the apical and perivaginal attachments. And the fact that you can see that apex and perivaginal add up to more than 100% is because these are really just two different measurements of the same phenomenon. In the upper right, you can see the correlation coefficient between these two different parameters, and you can see a very strong correlation coefficient between the two. Vaginal length is different, and vaginal width is actually not different in this sample. With larger samples, it may be, but it's certainly not a major player. But the hiatus, which is a completely different domain than the apical and the perivaginal supports, is responsible for a substantial causal portion. And that's what I'd like to focus on today, is our emerging understanding of the basic mechanisms of hiatus closure. It's really easy to see on physical examination. The normal individual has a hiatus that's 2 centimeters and a perineal body that's 2.5. The woman with a rectocele has a hiatus that's 5.5 centimeters, and the perineal body is 3 centimeters. So you can see that the perineal body itself is not a part of this process. It is definitively proven that this is true, although it's kind of like whack-a-mole to get people to stop talking about the perineal body as being the problem. The problem is hiatal closure, and that's what I'd like to talk about. Now, in a study that we did in 1998, where we measured hiatus size on physical examination, I still had a sizable general gynecology practice at that point, just simply took a ruler and made some measurements. And you can see in the graph on the right that there is a normal size to the hiatus that we see in the normals here. Women with unrepaired hiatus, unrepaired prolapse, had a substantially larger prolapse, a larger hiatus. That if they were cured of their prolapse, their hiatus was still larger than a normal woman's hiatus. If they'd failed one operation, it was still enlarged. And if they'd failed multiple operations, they had an even larger hiatus. So this suggested that two things. One is that an enlarged hiatus is associated with prolapse, and that the largest hiatuses were associated with operative failures. One of the questions has been the question about whether the prolapse causes the hiatus to enlarge or whether the enlarged hiatus is responsible for the prolapse. And this elegant study that Dr. Handa published this last year looked at women after vaginal delivery. They started, I think, 5 to 10 years, recruiting people 5 to 10 years after birth, and then followed them for up to 7 years. About 13% of these individuals developed prolapse below the hymen, and they had 754 controls then that could be matched with those individuals who developed prolapse. The genital hiatus was 20% larger among the women with prolapse than the women who didn't, 3.16 centimeters versus 2.62 centimeters. And the rate of increase in the genital hiatus was quite a bit larger. Now, it's important to realize that this larger hiatus was the hiatus at the time of enrollment, so before they developed the prolapse, which is the first data that is prospectively shown that a larger hiatus leads to prolapse later on in life. These are two scatter plots, the top one showing the cases versus the controls. And so if the cases and controls were equal, they would center along the line of unity at 45 degrees there, and you can see that they're substantially above. And when you actually match each case with their controls and look at that scatter plot, you can see a definite shift in the hiatus sizes, showing that the individuals who were cases or had prolapse were quite a bit larger at the time of enrollment than the controls. But is that really important to our surgical outcomes? Well, these are two studies that Tony's group has done. The first after native tissue vaginal repairs, and you can see with the Kaplan-Meier curve of persistent postoperative follow-up that individuals who had a stably normal hiatus, meaning it was normal before the operation and it stayed normal, had a pretty good long-term failure-free interval. But you can see if the individuals had improved hiatuses, or if it was persistently wide, that was, it did not improve afterwards, that they had a much higher failure rate, tying the size of the hiatus to operative failure. A similar study that they published also looked at the same thing after abdominal sacral colpopexy and found similar findings, with the persistently wide hiatus having a 2- or 3-fold higher failure rate than individuals who had an improved or a normal hiatus. Now, I would like to make a comment about how the hiatus is looked at. Most people look at it at straining, but the study that I had done years ago looked at it at rest. And I think that there still is a great importance to also looking at it rest. All 3 of these women with large prolapses that you can see in the top row had hiatuses that were 7 or 8 centimeters. And these are the same women with the prolapse repositioned. In the first one, you can see a huge hiatus. In the second one, you can see a moderately enlarged hiatus. And in the third one, this interesting woman actually had a perfectly normal, if not better than normal, hiatus, despite having a very large prolapse. Now, I would suggest that this third individual is the one who's going to have outstanding success no matter what operation you do. And I think that the first one, the one on the left, it's going to be a challenge to be able to get good success in that individual. So what are the factors that distinguish an individual with a normal hiatus, the one on the right, from an individual on the left who has a chronically failed hiatus? Well, let's take a look at what the hiatus is. So there are 2 hiatuses. One of them, the urogenital hiatus, is bordered in the front by the pubic bones, it's bordered on the sides by the levator ani, and it's bordered on the back by the perineal body. While the levator hiatus has the same borders except for the fact that it extends down behind the rectum, so therefore it's called the levator hiatus. When looked at in sagittal section, we can see the measurements that most people make from the pubic bone or from the urethra back to the front of the perineal body is the urogenital hiatus, and the one to the anorectal angle is the levator hiatus. Now, these are some beautiful drawings from Hallvan and Tandler's work at the beginning of this century, where they dissected cadavers with prolapse. You can see a normal individual on the left and an individual with prolapse on the right. You can see differences. For example, the perineal membrane, an important structure in level 3, is connected through the perineal body so that there's close attachment here. You can see that those points are widely separated in the individual who has prolapse. And because things are so interconnected, not only are those 2 points farther apart, but the relatively normal size hiatus between the medial borders of the levator that you see in a normal has a great diastasis that happens in an individual with prolapse. So not only is there a connective tissue element to this, which is important, but there's also a levator portion that we'll be talking about. Now, the levators are a mystery to most people. And I have to say that I've been looking at this for many years, and it's taken me a long time to understand it. But these observations are from a review of levator anatomy that we published a number of years ago, where we reviewed all of the primary descriptions. And it's actually very simple. There's 3 parts to the levator ani muscle: the pubococcygeus, the puborectalis, and the iliococcygeal muscle. And there are 3 parts of the pubococcygeus. So as you can see here, this pubic portion goes to the vagina, goes into the perineal body, and it goes to the anus. That's the pubococcygeus, which we sometimes refer to as the pubovisceral muscle: pubovaginal, puboperineal, puboanal. The puborectal is outside of those muscles and goes back to the anorectal junction back here, so that we've got the inside muscles and the outside muscles. Then the iliococcygeal muscle is back here in the back. Now I'm going to show you a dissection, and let you get oriented. The pubic bone is now over on the other side that you can see up at the top there. And this was a dissection late in the day when we'd already taken a lot of the organs out, but I think you can get oriented by looking at this little diagram. And what I'm going to do is to show you the effects of what goes on with these different components. Pubic bones in the front, then the bladder and urethra, vagina and uterus, rectum, and then I've marked the levator plate and put the anal sphincter in. Now, if we take those out, we can see the levator ani components. There's the pubococcygeal muscle here, and notice it going and attaching to the vagina, the perineal body, and the anus. There's the iliococcygeal muscle here, going back to the area back that's called the levator plate. And then peeking out between these two, as you'll see, is the puborectal muscle. So here, I'm taking a hold of the origin of the pubococcygeus and pulling it over to the side so that you can see the lateral puborectal muscle. It also starts up high on the pelvic bone. You can see that it's lateral to where the pubococcygeal muscle is, and it goes backwards to go to the anorectal angle in the levator plate, back in this area up above the external anal sphincter. So that's the more lateral of the two. And when you look at the pubococcygeal muscle, we can see why I call it the pubovisceral muscle, because of its elevating action for the vagina, the perineal body, and the anus, which are its attachments down here distally. And if we grab a hold of the origin of the pubococcygeal muscle, I guess I'm showing you the puborectal again. Oh yeah, in order to show you the edge of the iliococcygeal muscle back here. You can see the puborectal kind of tucking around just outside of that, back there, going to the anorectal angle. Now what we're going to do is to pull up and watch what happens when you activate the pubococcygeal muscle. You can see that it's elevating the vagina, it's elevating the perineal body, and it's elevating the anus. This is the specific action of the pubovisceral muscle or the pubococcygeal muscle. It is the muscle that becomes detached during childbirth. You can see when you lose that upward force, how radically that could change what's going on in terms of the mechanics of the pelvic floor. It's easy to palpate on vaginal exam. You can put your finger in and feel the lower border of the muscle, which is just at about the level of the perineal membrane, as we'll see in a few minutes. The iliococcygeal muscle, on the other hand, you can see has its action dorsally in the pelvis, back behind the rectum, in an area that would elevate and change the angle of the levator plate, although both of these actions could have an influence on the levator plate. Now, one of the important themes that I'd like to develop is this theme of interconnectedness, the levator ani muscles, the perineal membrane, the perineal body, and the connective tissues. And I'd like to show you some work that we've done on 3D reconstructions in conjunction with Bing Zi and several colleagues in Beijing. You can take an MRI. You can see where the organs are. You can move the scans out to the side until you can see the fiber directions. You can mark the fibers. And then you can make the fibers in a three-dimensional model in the direction that they normally go. This is a map of all of the different fibers in the levator ani muscle that you can see in this three-dimensional reconstruction. It's possible then to see the relationship of these to some of the surrounding structures. The pubovisceral muscle, as we said before, is an upward vector. The puborectal muscle is a more anteriorly directed vector. Now we can look at the connections in the following way. You can see the perineal membrane in blue, the levators in red, and we've now put the fibers in so that you can actually see the fibers of the levator. You can see the important connections between the levators and the perineal membrane shown by the blue dots in this diagram here, showing the complex nature of level 3 and the way that things are interconnected to one another. When you look at this in three-dimensional space, you can see that the vectors of the muscles will have a direct effect not only upon lifting the organs, but also in terms of the anatomy and the function of the perineal membrane, so that we really can't discuss either of those in isolation. It's necessary in order to be able to look at the interconnections to be able to understand that. Now, you can not only look at a normal situation, but you can also look at an individual with an abnormality. Here, we're showing a woman who has a unilateral levator defect. You can see on our left-hand side, her right-hand side, how the levator goes all the way up to the pubic bone. You can see on the contralateral side that the pubococcygeal portion is missing. This is a three-dimensional model of an individual who has that kind of defect. You can see a relatively normal side, as we saw before in the scan, but in the other side, you can see that that pubococcygeal muscle is missing, so that the vectors that would normally be attributable to the pubococcygeal muscle are lost in this individual. I think that this shows us the importance of being able to move beyond simply what we can see on physical examination in terms of our scientific understanding of what each individual's specific structural problem is. You can see that individual's photograph of her prolapse on the left, and you can see her three-dimensional model on the right. You can see that it's really not possible with just looking at the prolapse to be able to see what's going on with level 3, but with advanced imaging, now we're starting to be able to look at these different interactions. At the present time, we've been doing it with MRI, but I'm fully confident that ultrasound will very quickly be able to see the same things with ultrasound as an evaluation for understanding the specifics of the different things that are going on. So let's take a look at how complete our current approaches are. I'm a surgeon, always mighty proud to say, I'm always mighty proud to say it. I go to the operating room on Tuesdays and do my best for my patients to try and be able to correct the prolapses that they have. And we certainly have successes. And I think, as any experienced surgeon would say, we have some times that we wish that we had a better success rate than we have got. And in an MRI-based study that we did a couple of years ago, we actually looked at our ability to achieve normal after our operations. And when you think about it, we've got a lot of options to make the apex normal. This was 10 individuals. 90% of them had a normal apical operation, a normal apical outcome, but only 40% of them had a normal hiatus outcome afterwards. And that's despite the fact that all of these repairs were done by board-certified urogynecologists with extensive surgical experience and training. It is a humbling part of our current surgical approach. Now, it's not only the hiatus that's abnormal, and I'd like to move into understanding that a little bit more, that in addition to the fact that there are changes in the hiatus, in a normal individual, the bowl of the pelvic floor is shallow, whereas in an individual with prolapse, and as we can see in one of Hallban and Tandler's dissections, the entire bowl is deep. Yes, the hiatuses are larger, but the bowl has deepened substantially in addition to that. So to some extent, we're just starting to see the superficial aspects of a complete scientific understanding of what's going on in level 3. Now, just to expand upon our current understanding, what we currently do, we can look at this levator area as either an area in the mid-sagittal section or as a volume. And we can also look at the levator hiatus and the urogenital hiatus. And we're starting to recognize that these are quite related to one another, but they are actually separate phenomena. This is a conceptual framework that came out of the work that Carolyn Swenson in our group has been doing on some of these issues. And these are just theoretical diagrams of some of the different situations that we can see. In the upper left hand is a normal situation. The green arrows represent the urogenital and the levator hiatus. You can see the levator plate angle is relatively acute. The red band is the pubococcygeal muscle. The orange band is the puborectal muscle. And in the upper right, you can see what happens with aging. Carolyn studied older women who had no prolapse, and they had a more vertical levator plate. But the main thing is this deepening bowl that happens posteriorly, despite the fact that the hiatuses are no different in this than on the other. In the bottom panels, that's just illustrating the differences that you can see even without the hiatuses being different. Now, the bottom panel there shows the same kinds of things, but with enlarged hiatuses, so that each of these things is a partial picture of what's going on with the overall shape. And I think that we're getting a little bit better with that. And I think that even in the absence of changes in the hiatus, that if the bowl deepens, the vagina and the connective tissues are going to have to shift. And I think this is where we're starting to get a more complete appreciation of what's going on. That you can see in the upper diagram, the anterior vaginal wall, which I've just simply drawn in as a little band there, can lay on the supporting tissues. And once that drops downwards, you can see that the vagina wouldn't be able to rest on those, and then it would be moved posteriorly in order to be able to accommodate the dropping of the pelvic floor. This is some work that Emily English in our group presented at last year's AUGS meeting, and I'll take you through it just quickly here. What it is a whole series of measurements of these different pelvic floor things. If you look over here, these top measures were measures of the urogenital hiatus. The middle ones were changes in the levator hiatus. This is pelvic floor muscle strength, and this is levator defect down here. This is a correlation matrix, and so if you want to know the relationship between the urogenital hiatus at rest and the amount that it changes when somebody squeezes, it's 0.26. If you want to see the relationship between what it is at rest and what it is when somebody strains, the change with strain, it's 0.20. Now, what you realize is that the white squares are the things where there is no substantial correlation. There are only weak correlations in these areas between levator defect score and the change in urogenital hiatus that happens with straining. The larger the defect score, the more it changes with straining. But it's only an R of 0.3, which means that it only explains about 10%. You can see similar weak correlations here, and the only even moderate correlations are actually between things that are related. We would expect urogenital hiatus at rest and levator hiatus at rest to be correlated because they're two different measurements in the pelvic floor in basically the same area. The same thing with what goes on with levator and urogenital hiatus. So the take-home point from this is that there are many independent factors that each have their own role to play in what's going on. And it's not a simple system where strength results in larger hiatus or a levator defect results in a larger hiatus. It's more nuanced than that. And there's a lot of good data that's coming out now that helps us to be able to start to disentangle what's going on. So what can we do? Well, I think that if you asked people when they're thinking about an operative procedure, the only thing that we really do is a posterior repair in that area. And I think you can think that if you could put a stitch there and tie that, that would to some extent narrow the urogenital hiatus. But perhaps it isn't quite that simple. Maybe there's a little bit more going on than we thought about before. It is, however, a very important part of what we do. This is a photograph here. The patient's prolapse is seen in the upper left. We can see down here the completion. Her anterior repair has been done. Michigan 4 wall has gotten her apex up 9 centimeters above the introitus. And you could say that she doesn't have a rectocele anymore. She doesn't have a cystocele anymore, and she doesn't have an apical defect anymore. But I think if you grab the separated margins of the pelvic floor, so you're getting the medial parts of the levator ani muscle, and you're getting those separated edges of the perineal membrane, and you're holding those together and then doing a repair that reconnects those separated and diastatic, I guess diastatic's a word, correcting the diastasis of the levator muscles, that it sure looks a lot more normal afterwards. And I think there's a very important role for us to play in thinking about level 3. So for all of the fellows, if on an examination you were asked to list the number of operations for apical support and the outcomes of those operations in well-done studies, you'd have long lists in both. I think if we tried the same exercise for operations for hiatal failure, it would be a very short list, and I'm not sure that we have the kinds of outcome data that are comparable to what we have in individuals with apex. So I think the focus on the apex was the last 15 years or so. We've got lots of good operations for the apex, and I think you'll see in the next 10 years, lots of movement in terms of better understanding not only of what causes level 3 failure, but also looking at outcomes of different strategies for trying to correct that. So gold standard operations in the best of hands have about a 25% failure rate. We got a lot of good operations for apical support. We're early on in our understanding of the hiatus in the pelvic floor. We now have level 1 evidence that an enlarged hiatus is causal for pelvic organ prolapse. Failure of the hiatus to return to normal with operative procedures is associated with increased risk of recurrence. Closure of the hiatus involves the perineal membrane, the levator ani muscle, and level 3 connective tissue structures. And level 3 is more than just a hiatus. It's not just a single dimension. And it's not just what's present in an individual who's straining. It also differs in individuals at rest. I think for the fellows, this is a great area for many of you who are interested in an investigative career to start looking at. The more you look at it, the more you find that there's richness in the phenomena that are going on that we're only now starting to be able to address. Well, I would be remiss if I didn't thank all of my wonderful friends at Michigan and the Pelvic Floor Research Group who've produced a lot of this good work. And thank again AUGS and SGS for being able to facilitate this webinar. And I'll look forward to your questions and discussions. So I'll turn things over to Vicki and Tony. Be interested in your thoughts. Thanks very much.
All right, thank you so much, Dr. DeLancey, for a great presentation. As a reminder to everyone who's listening at home, please submit your questions through the Q&A section on Zoom, and we will answer as many of those questions as we can after the panel discussion. So do our panelists have any burning responses or thoughts so far?
I'll say that I think Dr. DeLancey did a great job of really providing some good data to support this emerging concept, which it helps us understand some of the surgical failures and also, more importantly, maybe some of the prevention opportunities. Because I think that if we believe that these hiatal measurements of structure and function are really causal, I think rather than focus on treatment, I would argue that we should focus on prevention. But that said, as we all know, interventions for prevention really have to rise to a higher bar, because you would be applying these hypothetical interventions to women who may never go on to develop prolapse. So I think the importance of prevention is obvious to most of us, but it's a very lofty goal in terms of identifying good solutions that would have high efficacy and also low risk of complications.
Yeah, I couldn't agree more. I think that, thank you, John, for going through that very, very nicely. Really decades worth of work. When you think about it, those are decades worth of observations that were really kind of refined and thoughtfully presented. I think that when you look at some of the potential out there to understand what is causing, why some patients recur and other patients don't, and we frankly on a very superficial level are talking the type of procedures that we're doing. And certainly there are differences between the procedures, but we don't fundamentally understand what the causative role of potentially the level 3 plays in recurrent prolapse. And I think this is just the start. I would encourage people to review this webinar several times, because it's really was chock full of so many different things that might actually help make us think differently about things that we sort of take for granted. It's not just doing a quick, what do you do a rectus repair, not at the end of the case. It's really a much more insightful and thoughtful sort of approach.
So we do have some great questions popping up in the chat from the attendees that I think we could get all of your perspectives on a couple of these here. So a common theme that's coming up is kind of how do you each approach your posterior repair when trying to optimize this returning to normal of the genital hiatus, and what principles do you use there?
Well, I'll take a first stab at that. Caroline knows exactly what it is that that goes on, and we take a triangular wedge of the posterior vaginal wall out, starting at the apex of the triangle, kind of mid-vagina, and then going out to where I showed those two Alices, that we estimate the size that we're trying to achieve, preview that by holding them together, getting the vaginal wall in the middle out, and then judiciously going out and getting stitches of the separated structures and trying to reconnect them in the midline. It's quite a different idea than people discuss when they talk about repairing the rectovaginal fascia, where they've got a layer concept, that there's a layer that's got to break and we're going to try and reconnect that. And there are some people who have a visible defect, but I think for me at least, trying to reconnect the two sides is the operative intervention that I'm usually looking at trying to accomplish when I'm thinking about the posterior compartment.
And I think what we try to enforce is that on the posterior vaginal wall, if you do have a thin vaginal wall, that the posterior vaginal wall that you don't think is just a discrete defect, that we usually close that in multiple layers. And I usually use my hands, and I'll just say, we put a row first and bring them together, then another row and bring it together, and then a third row sometimes to bring it together. So you're not just trying to go widely left to right and put things under tension. We literally check after every single stitch to make sure that we haven't created a ridge, because all these things in our attempt to do good might actually do harm, right? You might be causing dyspareunia, which might be a pretty significant problem. And then we I try to look at the posterior vaginal wall separate from the actual perineal body and try to make sure that there's continuity at the end surgically, generally by bringing left and right together at the perineal body, but make sure that doesn't happen, that you don't do a great posterior repair and then a great perineal body, but those two things are disconnected at the end of the case.
The only thing I'll add, I think we tend to think of posterior repair and perineography or perineoplasty together, but sometimes the patient really only needs the perineal body reconstruction. And I found that very often, if you look, you can see the edges of the remnant of the hymen. And very often those, it's almost like a horseshoe where the two more posterior aspects are just not connected to each other anymore, presumably from obstetrical injury or something. And so bringing those 2 points together, I often find is the most satisfying way to approach the kind of the architectural part of that repair.
Yeah, and I think in terms of a full picture of the posterior wall, both Vicki and Tony have hit on that, and that is that, one part is, if this is the posterior wall, there's the descent part that happens, which has to do with the elevation of the posterior vaginal wall. The other part is what happens down here, which is the, excuse me, the reconnection of the two sides. And so getting the posterior wall corrected is not just the level 3, but as Tony and Vicky have said, it's really an approach to both level 1 and level 2 and level 3.
And in a sort of the similar vein, there's a question that you could all address about whether any of you do imaging preoperatively to inform a site-specific repair, and whether you try to incorporate the levators specifically in your posterior repair.
We do a lot of imaging in our research program, and we don't really image people preoperatively for treatment planning yet. I've learned a tremendous number of things from doing imaging that's informed how I take care of patients, and I believe that sometime within the next 5 years, we'll be able to run a trial with and without imaging, where we can specifically have normal ranges for specific structural aspects. We'll be able to tell in each individual whether they're in the normal range or not, and then plan surgery based on that information, as opposed to doing what we all do, me included now, which is to kind of look at the overall situation and make a judgment. But we don't image everybody at the present time.
I would agree. I feel the imaging that we have now, I think, is not the imaging we need, in my opinion. I think that the imaging we have now is, various types of difficography, MRI difficography, ultrasound difficography, or fluoroscopic. And I think that does show the movement of the viscera. But I think those studies, I believe, are not very reproducible, and I'm sure the validity is not known as well. And so I think we need to wait to use imaging more thoughtfully once we really understand how it can change our management to improve outcomes. That's my opinion.
Yeah, I mean, we don't use imaging really for level 3. Certainly if you're worrying about an enteroceal and you think that's going to change your surgical planning. If you don't think it's going to change your surgical planning, we wouldn't do that.
There have been a lot of questions coming up in the chat about this concept of postoperative dyspareunia after a posterior repair. I know Dr. Visco touched on avoiding those ridges with each stitch, which I know we talk about with Dr. DeLancey as well. But a lot of people are bringing up the idea of how aggressive you try to bring the levators together and how that correlates with postoperative pain and how you would counsel your patients.
So Caroline, you're in your 3rd year in our fellowship. Have we seen a lot of people with dyspareunia from their posterior repair?
We do not.
So it is possible. I think that when you listen to all of us, we're talking about the care that it takes. And I think that it's one of the most underrated operations, that it's often at the end of a long operation and, we just want to put a few stitches and get done. But it is certainly properly placed stitches. It doesn't take a long time. I mean, the whole repair takes probably about 15 minutes, done carefully and well. So I think it is possible to do that. But just taking large blind bites without checking, as Tony says, to see whether there are ridges and things can create dyspareunia. But properly done, I don't think that it's a huge issue.
All right. And then I think here's a great question too of each of you could answer about what is your threshold for deciding to try to narrow someone's hiatus based on their hiatus after your apical repair?
Caroline, do you want to answer that?
Well, we do put those 2 Alices on like Dr. DeLancey showed and bring them together. And if there's more than about 2 centimeters in between those Alices and we take them back apart, then we would do our posterior repair.
Yeah, I mean, I think it depends on probably which approach we're taking and how bothersome the patient is with the posterior prolapse. We'll do an exam after an apical procedure and sort of make a clinical judgment. I don't think we have a particular cutoff, certainly based on that. And, perhaps we should, over, 4 seems to be the number, but it's probably not 4 for every single patient.
Yeah.
But I don't think we fully understand how to customize that decision making in that setting.
I think we have some data that we'll be publishing soon, hopefully, that suggests that there isn't a single threshold, that it's really a continuum of risk in terms of at least initially developing prolapse. My personal opinion is that I'm a kind of a less is more person, since we know, as Dr. Visco said, that there's maybe a 10% or something like that risk of dyspareunia with what we would call a posterior repair and perineoplasty. People consider that to be a pretty awful complication. So I definitely would tend to, avoid an additional repair if I'm not sure the patient needs it. And I've seen, as I'm sure others have, many patients where, and research suggests that this is true, that elevating the apex will often restore some closure of the hiatus, which is something we haven't really talked about,
Yeah.
but a really interesting phenomenon. And it doesn't make a lot of sense if you believe that the wide hiatus causes the prolapse, that fixing the prolapse would improve the hiatus, but it is something that's been observed. So for those reasons, I have kind of a high threshold, I would say, to do additional posterior repair in a patient who doesn't have something like a symptomatic rectocele or specific problem related to the perineal body.
Yeah, and I think Vicki brings up a really good point, and that is how recoverable is the enlarged hiatus. And all of us have had a patient who comes in with a huge hiatus, a huge prolapse. We put a Gellhorn pessary in, and then a month later, we can't get it out because everything has recovered and pulled up, and the hiatus is very normal. And then we've also had a very similar patient where it keeps falling out, or it stays in, but the hiatus continues to be gaping. It's kind of
because
like the.
I think there's a difference between the condition of the level 3 structures and the attachments of the level 3 structures. And I would speculate that if the attachments are the problem, you won't get that improvement with elevating the apex. Whereas if everything's all attached, it makes sense that pulling the apex up would be more successful in closing the hiatus. But that's just me speculating. I don't have any.
No,
data.
so Vicki, it actually in both of it might have some. I think there's something to that, because with the 2 studies that you referenced that our fellows did, looking at the general hiatus to see if it was persistently normal or improved or basically persistently widened. In those situations, basically there were 2 studies. One was sacrocolpopexy, one was native tissue repair. The thing that I found most interesting by just looking at, like, reviewing it for this webinar was that in the group that had the sacrocolpopexy, in that study, they only had half the number of posterior repairs done. Okay, so when you look at the persistently wide, the improved, and the stably normal, those were almost identical at the end, despite the fact that the vaginal group had twice as many posterior repairs. So there is probably something to a colpopexy-like apical suspension in those patients that we don't understand, because why? There's no other reason that they should have the same post-op basically results.
Yeah, and I think that would be, if we could come up with a way to predict who's going to have that recovery and who isn't, I think that we could cut down on the number of posterior repairs that we do and target them only to the people who weren't going to recover. I think that would be a great thing if somebody could figure out what it is that we could look at. Is it an elastin level in the tissue? We've been looking at an individual's ability to narrow the hiatus with a contraction. There are some people who have a large hiatus and you have them contract and boom, it's right up to normal. And another person that we do the same thing and it just lifts a little bit. You can tell that they're doing the right thing, but they don't have enough power to be able to do that. And kind of looking at more of those parameters to see who recovers and who doesn't. I think ASC is a good paradigm for that, because you do a great job of pulling the prolapse out of the way and then seeing who it is that recovers and who doesn't.
And I think I would just argue that until we have that predictive model that you're talking about, we've spent the last 10 years talking about treating occult incontinence, you know, and some people would argue that just treat the prolapse and then stage the treatment for the occult incontinence if it occurs. You could make the same argument with the genital hiatus, that if you do a prolapse operation and you find the hiatus is not narrowed, just like adding a sling on a second day in the OR, adding a level 3 procedure on another day, it's not as invasive as trying to undo the level 3 repair you wish you didn't do, or something like that.
No, that's actually a really interesting question, right? Because the alternative, you could do a posterior repair on everyone, right? Or the vast majority, and maybe you're doing harm by doing that. So maybe, I mean, I think we usually quote about a 5% risk based on some published studies that we've done, of the rate of needing a second procedure, specifically a posterior repair. But is it better to do that in that subgroup, or?
Yeah.
And we're not even sure that doing a posterior repair in the first place would have prevented that subsequent posterior defect. So that's also further complicates things.
I think for the young people listening in, you know, those are great clinical trials to run. Is, you know, if we can't figure out whether to do whether to do something or not, it seems perfectly reasonable to randomize people.
Well, and I think one of the great questions also could be, what are the effects of doing it? You know, just because we can make the genital hiatus measurement smaller, what did we really accomplish with that surgery? You know, what's the closure, what's the mobility, et cetera. There's lots of other structural and functional questions that you could ask about what seems to be the standard posterior repair or perineoplasty.
Yeah, you know, in some of the work that we've been doing recently, trying to understand muscle strength and hiatus closure and things, I say, you know, I kind of feel like somebody who's doing grip strength tests to figure out how good a pianist somebody is. You know, I think there's a very sophisticated mechanism in level 3, and right now we're kind of at the, you know, we're just looking at grip strength or how big somebody's hand is. And I think that fairly quickly, once people start to get interested in the science of this, I think that we'll pretty quickly be able to start to break it down into things and be able to predict things a little bit better. Is there other stuff on the chat, Caroline?
There were several questions about what you think the future of our surgical interventions might be to address the hiatus.
Good question. You know, I think it's going to be selection, as we've been talking about, is, you know, everybody can make a diagnosis of gestational diabetes. They know what the normal range is and they know what the cutoff is. And there's good data about what interventions are. And I think that's the next era for us, is actually getting numbers on some of these things and starting to look at outcomes where we say, if you do this intervention in this defined patient population 1 year and 5 years afterwards, this is the outcome. It's the symptomatic outcome. This is the anatomical outcome. And so I think that that's going to be the next phase, is starting to get out of the opinion part and start to get into the collecting evidence about this kind of thing. And there are enough of these operations done in centers that have good surgeons that know what they're doing, that it should be possible to be able to get that done. And then I think the other thing is going to be imaging, again, to be able to know who's going to benefit and who's not. We don't know it yet, but we're looking at 12-year follow-up data on women who had MRIs as part of some of our original mechanistic studies, where we can go back and measure the preoperative MRI from 12 years ago, and then look at measurements and see which ones predict success and failure. And we're finding some very interesting things, some of them kind of surprising to me, but I think that it's that kind of work where we actually systematically say, let's make some measurements, let's do our treatments, let's look at the outcomes, then look at what predicted what.
Well, we are unfortunately out of time now, but thank you so much, Dr. DeLancey, for a great presentation, and for our panelists, Dr. Handa, Dr. Visco, for such a great discussion and helping to answer all of these questions. Unfortunately, we didn't get to answer all of them, but so many great questions from the audience. I'd also like to, again, thank AUGS, SGS, and SUFU for putting together these informative webinars during this difficult time. And just a reminder that we are going to be putting on these webinars every Tuesday and Friday for our FPMRS fellows and anyone else who'd like to join for the education. And our next webinar will be held this Friday, April 24th at 10:30 a.m. Eastern. And we look forward to seeing you all then. And if you can't watch live, as a reminder, you can watch the archived version on each of the Society's websites or on the AUGS YouTube channel. So see you next time.
Thanks, Caroline.
Bye, Caroline. Thanks, everyone.
Bye-bye.
Thanks.